Hello and very warm welcome from the Secretariat of 20th Shaukat Khanum Annual Symposium. As you know, this is the prestigious symposium of the whole region, and we are very proud and humble at the same time to have eminent speakers from all around the globe. With me is Dr. Fawadul Kamar, who is working at Shaukat Khanum, Peshawar as a clinical oncologist. I have eminent list of speakers with me today. My first speaker I would like to introduce is Professor Stephanie Weiss, who is a professor at Fox Chase Cancer Center, Philadelphia, USA. She is the eminent speaker and considered an authority on CNS malignancies. Her expertise is evident from the fact that she is on NCCN panel for CNS malignancies. She is also the Radiation Oncology Residency and Fellowship Program Director at Fox Chase Cancer Center, and she will be presenting an update on latest trends on stereotactic radiosurgery for brain tumors and metastasis. So it's over to you, Dr. Stephanie Weiss.
Thank you very much. My name is Stephanie Weiss. I'm a professor of radiation oncology at Fox Chase Cancer Center, and I'll talk with you about the latest trends in stereotactic radiosurgery for brain metastases, specifically preoperative radiosurgery. The value of radiosurgery preoperatively is best understood within its historical context. Of course, whole brain radiation therapy has been around for decades and is certainly easy to deliver technologically. The downside, of course, is the neurosequela of whole brain radiation. In the 1990s, data came out that suggested that in the setting of a single metastases, adding surgery to whole brain radiation therapy offered certainly a local control benefit as well as a survival benefit and became the standard of care. Similarly, in the early 2000s, the benefit of radiosurgery added to whole brain radiation was demonstrated in patients with 3 or fewer metastases. Essentially, radiosurgery focused, therefore, high-dose radiation to the target, essentially acted in an ablative fashion comparable to what we get when we do invasive neurosurgery. The advantage, of course, being radiosurgery is non-invasive. Stereotactic radiosurgery uses multiple beams coming from different directions that allow us to create extremely conformal dosing around our target of interest. Similarly, it lets us avoid normal tissues such as the chiasm, the optic nerves, and the globes in the brainstem. This conformality allows an effectively ablative dose to our target. There are a variety of ways to immobilize and localize the patient. Whether or not this is a frame-based technique or frameless with a mask and image guidance, the outcomes are comparable. Here you see an enhancing lesion on the patient's anatomical left side. The lesion is contoured in the thick pink line that you can see. Surrounding that are isodose lines. Each colored line represents a dose level that falls off as you move further and further away from the target, much like ripples that emanate out after you throw a stone in a pond. By the time you start covering over the chiasm, certainly the brainstem, the percentage of dose relative to your prescription dose is merely a fraction and quite safe from a tolerability standpoint. These examples are somewhat dramatic. On the left panels, you see a lesion in panel A. On the anatomical right frontoparietal region, you can see an area around this enhancing lesion, which on FLAIR imaging would show considerable vasogenic edema. In panel B, you can see sometime after the radiosurgery, the vasogenic edema is gone. The lesion really is a remnant at this point. Interestingly, in panel C, it looks a little more solid, a few millimeters larger compared to the prior scan at B. This, in fact, is just treatment effect, essentially post-inflammatory, and eventually self-resolves over time, as you can see in panel D, a later time point. Another dramatic response here is shown on the panel on the right, a deep midbrain lesion on the right with considerable diminution afterwards. In fact, with most radiosurgery, we don't see such dramatic results, but radiographic response is far less important than simple control and the ability to get our patients off of steroids. So with the effectiveness of stereotactic radiosurgery, the question arose, is it possible to deliver SRS alone to patients with brain metastases and withhold neurotoxic whole brain radiation? And essentially the data that has come out in support of this has been very consistent. And there are about 4 or 5 randomized controlled trials between 2006 and 2017, all of which essentially show the same phenomena, that when radiosurgery is used alone for intact metastases, you essentially get control that is comparable to surgery. For single lesions, there's actually a survival benefit, just as there is when you do surgical resection. There are some patients who will nevertheless require resection, essentially patients who have a lot of mass effect, lesions that are very large and not technically amenable to radiosurgery, and when you need pathologic sampling. As the role of radiosurgery alone gained more traction, there began to be interest in investigating the feasibility of doing radiosurgery to a postoperative cavity. The issue had been that there was very little data that supported the safety of radiosurgery in the resection setting, that is, aiming high-dose radiation to effectively the margins of normal tissue rather than in intact metastases. The interest, however, began to take root once we realized we did not need to necessarily do whole brain radiation therapy for patients with multiple brain metastases. Therefore, having to do whole brain radiation therapy after resection of a single lesion seemed to be something that we'd want to be able to reduce. The first study by Soltis et al. Was published in 2008 that showed the feasibility of postoperative radiosurgery, and in fact showed it was safe and effective. The aligned study by Brown et al. Essentially turned the tables. So they demonstrated that the cognitive outcome after postoperative radiosurgery was superior for patients compared to those who received whole brain radiation postoperatively. At this point, the standard of care after resection was radiosurgery, where technically safe and feasible. There was, however, an interesting finding that was embedded in the Brown data, actually in the supplementary appendix. Remember, the endpoint of the study was neurocognition, not local control, and certainly postoperative radiosurgery was superior to whole brain radiation, although perhaps not as robust as we might expect. But what was interesting was the local control. There was certainly no arm comparing local control directly to intact lesions, but the 1-year local control in Brown et al. Was 61%. What was interesting was this was notably lower than the 1-year local control noted in the definitive randomized trials to intact lesions receiving radiosurgery, which was more around 70%. As the Alliance data was maturing, other data, including prospective data, observed that there was a surprisingly high incidence of leptomeningeal disease in the setting of postoperative radiosurgery. It was also observed that the incidence of radionecrosis in this setting was higher than expected and often higher than reported in the setting of radiosurgery to intact metastases. More recently, there's been some data that has been published suggesting that preoperative radiosurgery might be an interesting strategy for some patients. As you can see in the yellow column on the right, preoperative radiosurgery seems to have strong local control at 1 year of about 80%. One study reported 5-year control rate of 75%, which, if real, would even be higher than what we see in the intact radiosurgery setting. There's also suggestion that preoperative radiosurgery may have improved rates of leptomeningeal disease-free survival, as well as lower rates of radionecrosis than what we see in the postoperative setting, and perhaps even in the intact radiosurgery setting. Now, to give you a sense of how important it might be to raise local control of index lesions in the instance where a patient does require surgery, I turn your attention again back to the data from Brown in the Alliance trial. Remember, these patients received postoperative whole brain radiation versus postoperative radiosurgery. Postoperative radiosurgery had a local control rate of about 61% at 12 months. Compare this to the local control rate in the group that received postoperative whole brain radiation. Control was 81%. This was statistically significant, and again, buried in the supplementary appendix. It gives a good sense of the benchmark against which we want to strategize for the patients who do require invasive surgery. Now, with all the caveats that come with comparing data across studies, let's turn our attention to some hypothesis-generating data. When you look at the incidence of leptomeningeal disease for patients who receive radiosurgery either in the setting of intact brain metastases, postoperative radiosurgery, or preoperative radiosurgery, we see an incidence of LMD at 2 years in the intact setting of about 5 years. This goes up to 15 to 20% according to the data we have in the postoperative setting. The preliminary data that we have for leptomeningeal disease at the 2-year time point in the preoperative setting is 5%. There's a suggestion that preoperative radiosurgery may act essentially to sterilize the surgical field and limit the incidence of dissemination of disease in the operative setting. Keep in mind that leptomeningeal disease in this context, it includes not only nodular enhancement along the cavity and adjacent to it, but also disseminated carcinomatosis. These things are not well teased out in the data. Now let's turn our attention to the incidence of radionecrosis. The data for radionecrosis after radiosurgery intact lesions really is quite disparate. This probably reflects the fact that it wasn't really looked at robustly in earlier decades. More recently, people are coming to a consensus on how we come up with an endpoint to assess for radionecrosis, whether this uses surgery and tissue sampling versus various advanced imaging. Most clinicians quote an incidence of about 9%. In the data regarding radionecrosis in the postoperative setting, this is seen to be about 15 to 20% at 1 year and upwards to nearly 30% at 2 years, remarkably high. In the preoperative setting, however, the preliminary data shows an incidence of up to 5% at 1 year and up to 10% at 2 years. One report by Prabhu et al. Looked at the incidence of radionecrosis in these three contexts and found that radionecrosis was highest in the postoperative setting. It was lowest in the preoperative setting, and it was somewhere in between in the intact metastases setting. The thinking right now is that radionecrosis may be so high in patients who undergo postoperative radiosurgery because there's a challenge in defining the target in the postoperative setting. Furthermore, there might be a higher instance of radionecrosis due to the ischemia of the cavity after surgical manipulation. There's several ongoing trials right now you can find on clinicaltrials.gov, including dose escalation and de-escalation strategies in the setting of preoperative radiosurgery. There are several single-arm studies looking at local control as an endpoint, as well as a phase 3 study looking at local control comparing pre- and postoperative SRS. This is not yet recruiting. There's a phase 3 trial looking at leptomeningeal disease as the endpoint in an MD Anderson trial, and Mayo Clinic is looking at a phase 3 trial with a composite endpoint of a CNS event. That trial should be is estimated to be completed in 2025.
Thank you so much, Dr. Stephanie Weiss. I think there was some glitch in the video recording, but Stephanie will be definitely joining us soon from USA because it's very early in the morning right now, but she will be here around 7:45 or 8. So in the meanwhile, we will take our next presentation by Dr. Waqas Ishtiaq Ali, who is a consultant clinical oncologist at United Lancashire Hospitals NHS Trust in UK. And he will brief us regarding advances in breast cancer radiotherapy, making it more precise and optimum. So mic is over to you, Dr. Waqas. Thank you.
Good afternoon, everyone. And thank you to the organizing committee of this symposium to invite me for this talk. And I'm also grateful to the moderator of this session. I'm here to deliver a talk on advances in breast cancer radiation. And I will elaborate on two different dimensions. One, whether we have achieved optimum over a period of last few decades, and how precise are we these days as compared to past. Before I start my talk, these are my disclosures. And here I want to make a statement. Advances in radiotherapy technology has revolutionized breast cancer radiation over the past few decades. It has completely transformed its delivery from simple two-dimensional treatment to a collection of techniques that not only reduce the duration of treatment, but also improved therapeutic ratio by reducing toxicities and improving local control. These are basic numbers. We all agree that adjuvant radiotherapy reduces risk of local recurrence after breast conserving surgery and post-mastectomy in selected patients. And we also believe that preventing 4 local recurrences on average can prevent 1 breast cancer-related death at 10 years. But is it so simple to apply these numbers in clinical practice? The answer is no, because breast cancer is so diverse and we know more about it. I believe that tumor markers and genomics will help us in stratifying the risk of this disease in coming years. We can see from this meta-analysis that adjuvant radiotherapy after breast conserving surgery has significantly reduced the risk of local recurrence. Therefore, we see reduction in breast cancer specific mortality. And similar results can be seen in locally advanced patients where they had mastectomy and axillary clearance followed by radiotherapy. When we talk about optimum, have we really achieved optimum over a period of last few years? The answer is yes, as well as no. But when we talk about delivering less number of fractions with a similar or equivalent radiobiological dose, the answer is yes, we have achieved success. Have we become successful in radiating less tissue without compromising the outcome for certain type of patients? The answer is yes. Is it safe to omit radiotherapy in low-risk patients? The data is still evolving. And has radiotherapy replaced mutilating axillary dissection in some patients? The answer is yes. And have we learned that including internal mammary chain lymph nodes shown improvement in the outcome? The answer is yes. So let's talk about hypofractionation, because the journey began a few years ago when these trials have changed the practice. The traditional practice of radiotherapy was to deliver adjuvant radiation over a period of 5 to 7 weeks. But then we learned that giving high dose per day in less number of treatment sessions is equally good. And with the passage of time, the figures are encouraging and they're not showing an increased risk of recurrence. We were worried about the late-term outcome, and that was not even significantly higher in hypofractionated group. Last year during the pandemic, we got data from Fast Forward trial, and it was reassuring to see that there was no increased normal tissue effects due to extreme hypofractionation. So this trial, which was a non-inferiority trial, got 3 arms: control arm, test arm 1, and test arm 2. The test arm 2, where patients received 26 gray in 5 fractions over a period of 1 week, was the winner. The middle arm was not showing inferior in terms of tumor control, but the toxicity was more in that arm. The consensus here in UK is to consider 26 gray and 5 fractions for whole breast radiotherapy after breast conserving surgery, to the chest wall post mastectomy if indicated, and even to the reconstructed chest wall. For those patients who are eligible for partial breast radiation, this dose and fractionation can be used. But if you want to use boost, that must always be sequential with this hypofractionation. Patients needing radiotherapy to internal mammary chain was excluded from this trial. And so far, the standard of care is not to include these patients if you're going to deliver internal mammary chain nodal radiation. If you're just including the rest of the lymph nodes, still we are not using it routinely because we haven't got data from the nodal sub-study of Fast Forward trial. So we will wait until that time. The next topic is about radiating less tissue. And I'm talking about partial breast radiation. There are 2 ways to deliver partial breast radiation. One is through external beam, and the other is through multi-channel catheter brachytherapy. There is another way of delivering this, and that's intraoperative radiotherapy, but we did not get much encouraging result out of those trials. UK import law trial has established that partial breast radiotherapy is non-inferior to the whole breast radiation. Hence, we can utilize this option in patients older than 50 years, grade 1, grade 2, size less than 3 centimeter, and ER positive, HER2 negative, node negative, and adequately excised. we do not encourage to use this strategy in classical lobular and patients with extensive lymphovascular invasion. This is another interesting area, that how safely we can omit radiotherapy in low-risk patients. There is encouraging data, but there are some other trials which will be more helpful in future. According to the PRIME2 data, we can see that we can discuss omission of radiation in patients older than 65 years of age, predominantly stage 1 tumors, grade 1, grade 2, estrogen sensitive, hormone negative, HER2 negative, node negative, and completely excised. The presentation of T2 tumors were almost 10%, and only 3% were grade 3. So the consensus is not to include those patients who are grade 3 or any tumor size larger than 3 centimeters. So the 5-year data of this study showed similar risk of recurrence within the breast, and similar regional and distant recurrences with no difference in overall survival. Later, 10-year update was presented in San Antonio in 2020, where in breast recurrence was slightly higher, but in majority of the cases, it's manageable with the help of salvage surgery. Persistently, we saw similar regional and distant recurrences in both groups, and overall survival again was similar. So here I want to make some comments that you can discuss this option only with those patients who fall in this category, but those who are compliant with 5 years of endocrine treatment. If someone does not tolerate endocrine treatment, then revisiting your decision to consider radiotherapy would be a reasonable option. But if it will be too many months from the surgery or even years, then obviously you can't go back to give radiotherapy to these patients. We don't know about it, whether they will get benefit out of that or not. The other thing is that those patients who are going on endocrine treatment and we are omitting radiotherapy by considering them low risk, then they'll have to have a mammographic surveillance up to 10 years. In routine, we do mammographic surveillance up to 5 years, but in trial, they have done it for 10 years. So all these trials are also looking at omission of radiotherapy after breast conserving surgery, but they will seek help from tumor markers and genomic tests. So they probably will give us a bit more reliable idea about stratifying the risk of cancer and how safely we can omit it. Including internal memory chain and medial supraclavicular nodes for stage 1 to stage 3 breast cancer is another talk of the town, and there is a lot of discussion on this. There are 2 main trials. This trial has shown improvement in breast cancer mortality by considering internal memory chain nodal radiation, but there was no difference in overall survival, disease-free survival, or distant metastasis-free survival. Similarly, we can see in MA20 that in all type of patients, the trend is towards whole breast radiotherapy plus regional nodal irradiation, including internal memory chain, particularly in estrogen receptor negative patients. When you include internal memory chain, you always worried about cardiotoxicity and pulmonary toxicity. So luckily, the figures are non-significant and they're more or less the same in both groups. But surprisingly, there is more chance of lymphedema in regional nodal irradiation group. So the consensus here in UK is to consider regional nodal radiation, including internal memory chain for high risk, like T3, T4, N2, N3 disease, or intermediate risk with N1 if the tumor is central or medial. But we need to be careful about the organs at risk. So we should meet these constraints to keep doses lower. For heart, ipsilateral lung, mean contralateral dose should be less than 3.5 gray, and mean heart dose should be less than 6 gray. So the next thing is that can radiotherapy replace some part of surgical intervention? This is again a non-inferiority trial in which T1, T2 tumors, N0 were included, and those who were positive on sentinel node biopsy, they were further randomized between surgery and radiotherapy to axilla. The long-term results are encouraging, and we have seen that there is no increased risk of recurrence in those patients who received axillary radiotherapy instead of axillary clearance. There was similar overall survival and distant metastasis-free survival. The only difference noted was slightly more risk of second primary in the contralateral breast, but the actual numbers are very small. So we can conclude that axillary radiotherapy is a safe option for these patients who have got sentinel lymph node biopsy positive. But here the other question comes that there are some trials who suggest to omit axillary clearance or axillary radiotherapy, no further axillary management, and then are we overtreating these patients? Like Z11 trial or POSNOC trial, whose results are awaited, if they show positive results that further axillary management does not make any difference, then are we overtreating these patients? So we'll have to wait for those trials. Supporting role of other specialties cannot be ignored. Advancement in pathology, radiology, and surgical techniques, they all are contributors in improving outcome for breast cancer patients, and they are quite supportive in improving the decision-making in radiotherapy. When we talk about precision, we cannot ignore planning and delivery. So these days, we are heading towards Tattooless breast treatment using surface-guided radiotherapy. We also are successful to reduce the cardiotoxicity by using different techniques. Contouring the volumes is very important. Again, I think breast radiotherapy is lagging behind. We have already moved to precisely contour the gross tumor volume or clinical tumor volume for other tumor sites. But now the practice is rapidly changing, and many centers in this country and across the world have adopted this technique. VMAT is another advanced way of delivering radiation, which many centers have implemented this in their practice. So let's start with Tattooless breast treatment using surface-guided radiotherapy. I mean, what's the problem with tattoos? One challenge is that permanency of these tattoos. In some patients, it gives negative impact on cosmetic, and it keeps on reminding you about diagnosis and its treatment. Alignment of these tattoos is fundamentally limited and potentially not sufficient for modern advanced radiotherapy. So what we're using these days, you can see a camera on the top of this screen, and these cameras are placed on right and left and one on the foot end. This is a 3D imaging solution for patient setup and real-time tracking in RT. It's currently utilizing Align RT for motion management, contour, and setup evaluation. It's non-invasive technique, does not require markers, does not require any additional radiation. It gives a complete patient position instead of just 3 tattoos. It's based on 20,000 reference points. It also deals with rotations, pitch, rotation, roll before imaging. It allows live monitoring during treatment for patient movement, and it is also helpful in DI-based treatments to deliver them safely and accurately. So cardiotoxicity, if you look at the picture here, the left anterior descending and left circumflex arteries are quite close to the chest wall. We know that cardiotoxicity is mainly due to macrovascular damage, particularly to the LAD. And the figures are quite astonishing that radiotherapy increases the rate of major coronary events by 7.5% per gray with no apparent threshold. So it is important to look into the options to reduce this toxicity. If you look at the diagram here, you can see that how much is the displacement of heart with motion. So we can use different techniques to distance the heart from the chest wall, like DIBH, deep inspiratory breath hold, respiratory gating, prone position for the large breaths. Partial breast radiotherapy, again, is an option, but it's not always successful. And proton therapy is not available in every center. So UK heart spare study is a multicentric study to evaluate voluntary breath hold technique in patients receiving breast radiotherapy, and it has shown promising results with the reduction of dose to this organ at risk. So deep breath hold, what it is, it's a supervised breath hold in deep inspiration for 20 seconds to 25 seconds. It helps in reducing the respiratory motion, and it increases the normal tissue sparing. You can see that how much distance we have achieved with this technique between the heart and the chest wall, and the left lung gets and the expansion of the left lung helps us to achieve this. Without this, you can see that how close the heart, particularly this little dot, is LAD, left anterior descending artery, which is the major area of concern. On the bottom, you can see a dose volume histogram, and the bottom line is the one with the DIBH technique, and you can see a sharp difference between free breathing and DIBH. Similarly, on these images, you can see a significant part of heart is in the radiation field. There are challenges. I mean, some patients, they are unable to reproduce it. Some patients with difficulty breathing, difficulties like COPD, they can't manage it. Chest wall movement, if it's less than 5 millimeter, again, you can't achieve it. And those who are unable to understand instructions, it's very hard for them to manage it. Patient requiring Vaclock, again, struggle with this technique. Contouring the volumes. Again, as I've said, that it is important to precisely delineate the area of concern where you're targeting. And without contouring, it is not possible. Traditional way of delivering radiotherapy was not giving us a reliable picture. So here you can see different levels, but if you look at this diagram on this side, you can see different levels of different nodal levels, starting from level 1, level 2, level 3, and then level 4. And this pink line is internal memory chain lymph nodes. You can seek help for contouring from ESTRO guidelines, RTOG atlases. They all are helpful, and there are so many tools available to learn about this contouring. So looking at the contouring volumes for SCF, just an example, you can see that that's the traditional field we were using for SCF, and you can see it was quite tall. And according to the contoured nodes, now if you fit these contoured nodes into this SCF field, you can see that you can easily miss it on the lateral side, and unnecessarily it is extended superiorly. So that's exactly what is needed. So you can see that it's quite different from the traditional SCF field. Boost. Again, we all know that dose escalation improves local control. And therefore, we consider boost after whole breast radiotherapy in certain patients who are having high-risk cancer, high-grade tumor, or tumor with positive margins, or which cannot be surgically revised, or patients with extensive intraductal component, or if they're younger in age, then boost is always helpful. Boost only improves local control. It has got no impact on the overall survival. But it is very important to precisely target the tumor cavity. Traditionally, we were just making assessments through the scar. So it was scar-based, which was not very accurate, and you can see that how easily you can miss it. Clinical judgment with the help of pre-op imaging and operative notes was slightly better than the scar-based approach. CT-based approach is more appropriate. And if the surgeons leave clips in the tumor cavity, then it makes life easier for the radiation oncologist. It's the standard of care now for the surgeons to leave the clips, particularly since they have been using newer surgical techniques like therapeutic mammoplasty, where you can't identify a cavity unless there is a seroma there. So, so surgical clips are extremely helpful to delineate the tumor bed. And then delivery of radiation, we can see that we started from standard fields, and as compared to standard fields, the mono IMRT technique improved coverage, reduced the hot spots, hot dose regions, but it was quite challenging to plan. So VMAT, volumetric modulated arc therapy, has significantly improved tumor coverage, and it takes less time to plan with no time difference on the treatment machine. And these figures, the last one is showing the plan with the VMAT. Future dimensions. There are a few trials which are looking into important questions. Europa trial is looking whether radiotherapy alone versus endocrine therapy alone in low-risk patients. And the next one is IBCSG. Basically, this trial has already established that axillary node dissection is not needed if we find micrometastatic disease on sentinel node biopsy. And we have extrapolated from this that no radiotherapy is needed for these patients. But to be fair, I mean, if there is more than one micrometastatic disease, if there are more than one node, 3 nodes on sentinel, what to do with them, we don't know. So Alliance trial will give us an answer that what to do with the patients who still got residual disease after neoadjuvant chemotherapy. Would it be all right to give radiotherapy alone to them, or do we need to do axillary node clearance with radiation? NSA-BP 51 again is looking at a similar question, that those who achieve complete pathological response with effective neoadjuvant chemotherapy response, what to do with them? Do we still need to consider radiotherapy in post-operative setting, or we can omit it? I've already mentioned about POSNOC. In POSNOC, we are seeing that further axillary management is needed if there is 1 to 2 lymph node positive, or omission of axillary management is safe. MA39 and NRG 007, they both are looking at the role of radiotherapy by using genomics in low-risk patients. So this probably will set up the future stage for breast cancer radiotherapy. We will definitely get some exciting results out of these trials. So thank you very much. If you have any question, you can ask the panelists during the panel discussion, or you can email me if you like to do so. Thank you.
Well, thank you so much, Dr. Vikas. This was an excellent slide, an excellent presentation on breast radiotherapy. We will now switch our gears to physics of stereotactic radiotherapy and what are the tools for plan evaluation. Certainly, this is very important when you do a SBRT planning. You need good physics support for your backup. And I will invite Dr. Ahmed Aldeeb, who is assistant professor at Fox Chase Cancer University in the Department of Medical Physics. All yours, Dr. Ahmed. Thank you.
Thanks for inviting me to the symposium. I'll be glad to talk today about physics of stereotactic radiotherapy plan evaluation. The outline of the talk is a brief introduction. Then I will talk about SBRT plan evaluation. Then I would like to share with you some results comparing different plans from different stereotactic machines. And then I will end with a conclusion. There are two types, cranial and extracranial. We usually call the extracranial as SBRT. And some people like to call it the stereotactic ablative body radiotherapy. TG42 from the AAPM have as definition, stereotactic radiosurgery of an intracranial lesion combine the use of stereotactic apparatus and energetic radiation beams to radiate the lesion with a single treatment. If you use a stereotactic apparatus and radiation beams for multiple fractions, then we usually call this stereotactic radiotherapy. SBRT Astro have a definition. It's an external beam radiation therapy method used to very precisely deliver a high dose of radiation to extracranial target within the body using either single or few fractions. Specialized treatment planning results in high target dose and steep dose gradient beyond the target, and the ability to deliver single or few fractions of high dose with high targeting accuracy and rapid dose follow-off is actually the basis of the SBRT. TG101 from AAPM also have a definition. The major features that separate SBRT from conventional is delivery of large doses in few fractions, resulting in a high effective biological dose. In order to minimize normal tissue toxicity, conformation of high doses to the target and the rapid fall-off away from the target is critical. The practice of SBRT therefore requires high level of confidence in the accuracy of the entire treatment delivery process. This high level of confidence is accomplished by integration of modern imaging, simulation, treatment planning, and delivery technologies into all phases of the treatment process, from treatment simulation planning and continuing throughout beam delivery. TG101 have recommendations, and I will summarize some of them here. Simulation imaging study should cover the target and all organs at risk. Scan length should be 5 to 10 cm, superior and inferior, and if you are doing non-coplanars, then it should be 15. And slide thickness should be 1 to 3 millimeter. Imaging artifact, if target and radiosensitive critical structures cannot be localized because of artifacts caused by motion or metal artifact, then at that time SBRT shouldn't be used. Calculation grid size should be 2 millimeter or less, and 3 millimeter is actually discouraged. Beam energy, we know the higher the beam energy, the larger the beam penumbra. It's more significant in low-density mediums such as lung. And that's why we usually use 6 MV instead of 10, for example, because 6 MV actually provide a reasonable compromise between the beam penetration and the penumbra characteristics for the SBRT lung applications. Resolution of beam shaping, what MLC widths I should use. So 5 millimeter has been found to be adequate. The report stated, if you think that 3 millimeter is better, actually the report stated there is negligible improvement using the 3 millimeter unless you will be using a target with 3 cm diameter or less. So what do you need to do for your stereotactic problem? First, you need to think, what machines are we going to use? What size are we going to treat? And how many patients can we treat? And the cost, because you don't want to buy a very expensive machine and then end up treating just few patients. So machines, Gamma Knife is one of the successful machines in the market. It have the latest design have 192 cobalt sources arranged in 8 motorized sectors, each containing 24 sources. But what is the limitation of this machine? It only treats cranial cases, doesn't treat extracranial cases. So CyberKnife is another machine. It treats both cranial and extracranial cases. And the limitation of this machine is that gantry currently cannot point upward more than 18 to 22 degrees above the horizontal. So if you look here in these pictures, there is no posterior beams. Linear accelerators treat cranial and extracranial cases. This is really also a nice machine. But the machine limitation is they have less beam oblique angles if you compare it with the Gamma knife and CyberKnives. Studies in literature, you can see a lot of papers published. This one here compares X knife versus Gamma knife. They showed that the dose conformity and dose follow-up is better with the Gamma knife. This paper compares Gamma knife, CyberKnife, and Linac Novalis. They show the Gamma knife and CyberKnife actually can achieve better target dose conformity compared to the Novalis. But on the other hand, Novalis and CyberKnife also show that they can provide, if you are looking for a more homogeneous dose distribution, then Novalis and CyberKnife is more capable. Gamma knife and CyberKnife, this paper showed that actually Gamma knife can provide the steepest dose gradient. This paper here, Gamma knife, CyberKnife, and Linac, they show that three modalities are capable of treating multiple large brain lesions. But they show that Linac, on the other hand, is superior regarding the treatment time. They can treat in shorter time. A lot of machines can be found in market. It's important that you make sure that you know what's the limitation of the machines and if these machines will be really beneficial to your patient. Reference and protocols, RTOG protocols is a good references, can provide good references. You can download the protocol from this website, and those will give you guide regarding those prescription, target coverage, those constraints. Those references are good for physics, TG42, TG101, TG172. You can find a lot of task groups important for stereotactic radiosurgery and stereotactic body radiation therapy. Also, a good source of information is a virtual library from the AAPM website. They have a database of different presentations that were recorded and saved from different annual meetings. Now I will comment about the expertise plan evaluation. I will comment first about what you should think of before planning, and then final evaluation. So pre-planning, be aware of your machine limitation. For example, here, for variant accelerator to ensure clearance, if you look in this picture here, the stated that we should have 22 cm or less between the isocenter and the patient and the couch top. Otherwise, collision can occur. So make sure you meet this. Otherwise, you can have a collision between the gantry and the couch. So the isocenter here for this target, you can see it's in the middle of the target. But you can see that now I'm not meeting the limit. It's 23, and I would like it to be 22 at least. So if you look here, to solve this, we moved to make this 19.13 here, 19. So it's not in the order of 19. But this is still a problem because I will explain why. Because there is another limitation. The MLC leaves are 15 centimeter long, and two opposite leaves moving parallel to its jaws can only cover up to 30 cm. So if you look here in this video, because now the isocenter is not in the middle, so the target have to rotate through a larger area, now the settings of my field become bigger to make sure that the target is always within this field. But by doing this, I'm actually not meeting the limit that was stated by variant for the jaws for the field settings here. So the only solution for this was not the only solution, but the solution we did the partial arc instead of full arc, and the iso shift was still done, but with vertical distance less than 22 cm. So we did another shift, but this time we make a smaller shift. So I'm still meeting this. And on another hand, also I put the couch, the partial arc instead of full arc to make sure I'm not colliding with bars here. So you can always think of different solutions, but it's really important to make sure that you fix this before you treat the patient. So you can always do a dry run before you go and have the patient on the table. The consequence can be aware of your machine limitation, because the consequences can be bad. For example, this paper here showed an example where the brainstem here is not covered by the leaves because of the limit for the leaf motion here. So really, if you don't know the limits of the machine, then you can end up doing an inefficient use of your TPS, and you can end up having a bad quality plan. So anything else pre-planning? Yes, you have to have in your hand the planning goal. So you can get that from the RTU protocol, for example, for lung. You can see they have stated some goals for that target. So maximum dose normalized to 100 must be within BTV. Prescribed isodose line must be between 60 and 90 of the maximum dose. 95% of BTV is covered by prescription. 99% of BTV receives a minimum of 90% of prescription. And the maximum dose at 2 cm from BTV in any direction should be less than 50% of the prescribed dose. You can look at the table. Lung RTUG have a table recommending D2CM as a function of BTV volume. Example, for 163 cc, the recommendation is D2CM equals 77%. So D2CM is a structure with row, it's a ring structure with rows, 2 cm away from the target, and we try to look at the maximum dose at this structure and try to make sure it meets these limits. Another thing you should have in your hand, the constraints for the organs at risk. So in my institutions, we are using Timmerman tables. This is an example of 5 fractions. You see here the list a lot of constraints for the volume constraints and the maximum point dose constraints. So let's start planning. So planning is we start with doing the plan, and then we evaluate the plan, and then if not the best, we go back and do another plan, and we keep doing that until the physics are happy. Then we call the physician and they come, and if they do the plan, they check, they can give us a feedback. They can have some concern regarding some critical structures, so they might ask us to push more. Then we do another plan, and so it's a loop that continues. Evaluation. We evaluate those parameters, those volume histogram, conformity index, dose distribution, and the fall-off. We use DTCM to quantify the fall-off. Those volume histogram, we start with, like for example, let's see here, this is an example. You just look at the 100% prescription, and we make sure it's better than 95. And you also consider all the other parameters. And for example, here also another thing is the maximum. We usually use the 0.035 cc as a point for maximum point to represent the maximum point dose. And we have a template for the different critical structures for the specific site we are treating. And really to have a template with all the critical structures listed that you are expecting to see is important, because it helps not to miss any, and not to forget to evaluate any of the critical structures. So after you finish your plan, you list all the numbers, and you make sure if they meet the goal, you say yes here. So that's what we do. And it's really important to keep trying, even if you pass, because like here, I was passing the criteria, and but after trying first time, but after trying more, I can actually lower the dose to the point. So it's really important to keep trying. RTG-CI is defined as we quantify the conformity by using this index, which is defined as the volume of the prescription divided by the planning target volume. So if you see here, if this is the ISO's line of the prescription and the target is the red, you can see if you divide both volumes, and the CI will be equal to 1. But it's very important to make sure that you look at the ISO's lines, because here you can see the ISO's line can be totally out, but you still, because they have the same volume, it will be equal to 1. So it's really important if you use this definition to make sure you compare the ISO's lines. And that's why some others came out with other conformity index definitions, like this BEDIC here. You see the target volume covered by prescription ISO's volume square divided by this. If you rearrange this equation here, these parameters here, you can actually get here this form where this is actually the coverage, and this is actually the 1 over CI, this CI. So if you make this, so if you look at this table here, this is again this table is summarizing the different situations. So you can see still like it's actually equivalent to use this and this. If you like using one single number, then you use the BEDIC. But if you don't like using but if you use BEDIC, you have to make sure you understand carefully what the good numbers is and what the bad numbers is. So the best is 1 here, as we can see. So, or on the other hand, if you don't like using BEDIC, is still equivalent. If you make sure the coverage is good and the CI is good, then it's actually the same thing. Conformity index, when you look here, you can see it's 1.1 for this plan as an example, and you can look at the dose distribution. It can be accepted, but actually we can do better. So how can we do better? You can see here it's CI equal 1.08, and the plan now is better. So how we did this? This was a 3D plan. So we manually moved the MLC to improve the conformity, and we adjust the field weights. Previously, it was everything here is 1, and we can see we changed the weights for lower the weight for certain fields and increase for others, and that's how it works. To adjust the CI, if you do inverse planning, then you can always have a ring structure. And you can always put some limits during the optimization to make sure the conformity is push the optimization to get you a better conformity. The D2CM, we use it to quantify the fall off. So you can see this is a D2CM structure, and you can see here successfully we were able to have the 27, which is here is 50% of the prescription to be within the within the D2CM structure. And of course, if you are doing inverse planning, and you can always put some limits on this structure during the optimization process. I will share here some results. There was novel rotating machines designed that we were studying in our institution. So one design is the Cypre design, and this is a Galaxy design. These have ring gantry containing 13 cobalt sources focused at the isocenter. Those sources can rotate, and these 30 cobalt sources positioned along 30 arcs and rotate as a group in an axis or similar to the patient body. So you can see that those machines are trying to use less sources compared to gamma knife, and still get the same results. So we compare those two designs to see how efficient are they. So you can see both of them can actually here cover the target. One of them was better than the other for the critical structure here, but both actually is meeting our criteria. One of them is a Cypre was longer treatment compared to the Galaxy, have a shorter treatment. Coverage is comparable, but on the other hand, CI was better with Galaxy. So in summary, the Galaxy was faster, have shown faster fall off in the axial view. Both systems showed the ability to accomplish treatment with less sources, resulting in a significant overall cost saving. The ring configuration of Cypre can have an advantage because it's this ring configuration can allow this machine to treat also extracranial. So this is the advantage of Cypre compared to Galaxy. So you can see we compare now Cypre with CyberKnife, since both can do extra and cranial and extracranial. So Cypre here have circular isos lines, as you can see here, compared to CyberKnife. Here they have comparable results. They both meet the constraints for the critical structures, but CyberKnife was and Cypre for the target, both can cover, but one was hotter than the other. The time for treatment is actually shorter with Cypre, but CyberKnife doesn't need to change sources. So as long as you periodically change the cobalt sources, then you might keep the differences here. Cypre is not as good as CyberKnife in conformity. So conformity 1.28 here is the mean is for those 10 cases actually is better with CyberKnife. But on the other hand, the fall off is better with Cypre. So you can see here the maximum for the D2CM is higher with the CyberKnife. So in summary, the dosimetric parameters of the novel systems allow its use for small intracranial lesions. These non-compliant and multiple source arrangements carries clinical benefit, potential for stereotactic intracranial radiation therapy. Then Cypre versus CyberKnife for SPRT. For extracranial, we try now to look at the extracranial cases. So you can see here again, the Cypre have the characteristic kind of oval-shaped isos lines here compared to here with CyberKnife. You can see a lot of spikes. So these spikes is we wanted to quantify the differences. So we created a structure called D5CM. See again, the deviations are, you can say it's comparable for some critical structures. One can be better on one thing and the other can be better on another. The D5CM is better for Cypre. As you can see, the maximum is higher here for CyberKnife. So this is the fall off is better with Cypre. Time-wise, you can see there's a smaller like here is the cypher is better. So in summary, cypher was superior with regard to the preferred doses appearing as excess dose spikes. So it's better with cypher. So there is no excessive isos lying extending to distal normal tissues. Better target with conformity was often achieved by cyber knife. It's mostly with large irregular shaped targets because cyber knife is capable of doing optimization of the individual beam weights. So plan quality of cyber knife plans may be further improved. Cyber knife can improve their plans if they can do posterior fields. Cyber knife, on the other hand, can improve if they do optimization because they currently don't do any optimization. So if they do optimization, by optimizing, combining the collimator, change, beam weight modulation, and couch movement during anti-rotation, the current system actually is capable of doing that, but they don't have that yet. So if they do that, they can improve the results. VMAT and CyberKnife and CyberA was also compared in some cases, and you can see again the characteristics of the isos lines between the three machines. They can have comparable results for the deviations here, as you can see, CyberA versus CyberKnife. You can see one can be better than the other in some, but can be different than others. So here CI was better for the LINAC compared to the others, and the time was better with the LINAC compared to the others. But other than that, the coverage was comparable. So the summary is the CyberA was superior with respect to the fall off outside the target, but the VMAT and CK was achieving more conformal. So the final conclusion is the plan quality and dose delivery efficiency is highly dependent on machine radiation workspace, and the rotational delivery has the advantage of smooth isos lines that don't produce spikes or finger-shaped dose projections. Thank you. That's my last slide.
Well, thank you so much, Dr. Ahmed. This was an excellent presentation. And without a further time, I will invite Dr. Kamran Saeed, who is working as consultant radiation oncologist at Jinnah Postgraduate Medical Center in Pakistan, to present some CyberKnife robotic radiosurgery experience locally from Pakistan. So stage is yours, Dr. Kamran Saeed. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Kamran Saeed. I am working as consultant radiation oncologist in CyberKnife Robotic Radiosurgery Department run by Patients Aid Foundation. We have 9-year experience in doing whole body radiosurgery. We offer free treatment of radiosurgery. There is no cash counter at our center. I will present our data of different pathologies to make it more attractive. I have added our treatment images that will precede each pathology. I start with gliomas. This is image of glioblastoma multiforme. On the left is the image of pre-radiosurgery. On the right is post-radiosurgery image. This is image of our treated astrocytoma. This is image of gliosarcoma. And this is image of medulloblastoma. Now coming to our data of low-grade gliomas, all cases previously underwent surgery, conventional radiation therapy, and chemotherapy. Total cases are 60, age ranged from 8 to 46 years. Radiological progression was seen in 29% of our cases, and radiological control in the form of complete remission, reduction, or stable status was seen in 71% of our cases. This is data of high-grade gliomas. Again, all the patients were previously treated. Total cases are 76. No follow-ups were seen in 25%. Age ranged from 8 to 64 years. Development of new lesion was seen in 11%. Radiological progression was seen in 25%. And radiological control in the form of complete remission, reduction, or stable status was seen in 71%. Now coming to brain metastasis. We treated this patient with 28 brain metastases. The patient has non-small cell lung primary. The patient was referred to us after whole brain radiosurgery, and this is his follow-up images. The patient survived 16 months post-radiosurgery and ultimately lost his life to the progression of the primary disease. Now coming to our treated cases, this is the image of one of our treated cases of brain metastasis. This is another image of brain metastasis, another image of our treated case. Now coming to our data, total cases are 289. No follow-ups were seen in 31%. Females are 70%, and the breast was the leading pathology with 25%. Radiological progression was seen in 5% of our treated cases. Development of new mets during follow-up was seen in 19%. 32% of our patients died during follow-ups. Radiological control was seen in 95% of our treated cases. We have also done radiosurgery of bone pathologies. We have treated chordomas, chondrosarcomas, relapsed osteosarcomas, giant cell tumors, relapsed eating sarcomas, and bone metastasis. This is the image of skull-based chondrosarcoma. This is image of our treated chordoma clivus. This is image of sacral chordoma. Our treated case of a skull-based giant cell tumor. This is bone metastasis from renal primary. This is our data for chordomas. Total cases are 18. Age range from 18 to 62 years. Site of the primary disease was clivus, cervical spine, and sacrum. Radiological control in the form of reduction or stable status was seen in 94% of our treated cases. Now coming to our data for acoustic neuroma. This is image of left acoustic neuroma. This is image of our treated right acoustic neuroma. This is the case of neurofibromatosis 2 with bilateral acoustic neuromas. This is our data. Total cases are 437. No follow-ups were seen in 13%. Audiometry was deteriorated in 14% and improved or stable in 86% of our treated cases. Radiological progression was seen in 2%, and radiological control was seen in 98% of our treated cases. These are the examples of schwannomas we treated. This is a case of right trigeminal schwannoma. This is the image of right facial nerve schwannoma. This is the image of right hypoglossal nerve schwannoma. And this is left paracavernous schwannoma. Now coming to arteriovenous malformations. This is the image of our treated case. Another example of our treated case. This image shows the timeline towards obliteration of the nidus. We all know that the latency period for the obliteration of nidus is 3 years. On the extreme right, this image represents 1 year post-radiosurgery. On the second image is 2 years post-radiosurgery. And the third image is 3 years post-radiosurgery. And the complete obliteration of the nidus was confirmed on CT angiography. This is the data of our AVMs. Total cases are 353. No follow-ups were seen in 21%. Pediatric population was 19%. Allocated location was seen in 15%. Pre-SRS bleed was seen in 49% of our treated cases. Radiological stable nidus was seen in 6%. Radiological control or complete obliteration of nidus was seen in 14%. Radiologically reduced nidus was seen in 78%. Coming to side effects, edema was seen in 29%, and reversible radiation changes were seen in 10% of our treated cases. We also treat cavernomas. This is the image of our treated case. We started treating cavernomas very late, and total cases are 20. The indications of radiosurgery is repeat bleed, uncontrollable seizures, and surgically not doable case. What is the goal of radiosurgery? Is to prevent rebleed, and there is 100% control in all of our treated cases. I want to say something about pineal region tumors. We all know that this region contains a wide spectrum of pathologies: germ cell tumors, pineal parenchymal tumors, glial tumors, and miscellaneous tumors. It's only the pineocytoma, papillary tumor of pineal origin, metastasis, and meningioma that need radiosurgical treatment, while all other pathologies need conventional radiation with or without chemotherapy. So it's very important to do biopsy of these lesions, and please do not treat pineal region tumors without doing biopsy. Now coming to glomus tumor or paraganglioma. This is our treated case of right paraganglioma. This is a case of bilateral glomus tumor. This is our data. Total cases are 111. No follow-ups were seen in 18%. Radiological progression was seen in 2%, and radiological control was seen in 98% of our treated cases. Now coming to pituitary adenomas. This is the image of our treated case. And last image of our treated case. Non-functional pituitary adenoma data, total cases are 165. Upfront surgery was done in 89% of our cases. Post-SRS pituitary hypofunction was seen in 10% of our treated cases. Perimetry was worsened in 2%, while it was improved and seen in 75% of our cases. Radiological control was seen in 98% of our treated cases. Coming to acromegaly, total cases are 88. Upfront surgery was done in 84%. Post-SRS pituitary hypofunction was seen in 4%. Radiological control was seen in 84%. Biochemical uncontrolled patients were 7%, while 28% of our patients achieved complete remission and 52% showed reduction of excess hormone excretion. Coming to Cushing disease, total cases are 17. Upfront surgery was done in 65%. Post-SRS pituitary hypofunction was seen in 12%. Radiological control was seen in 82% of our cases. Biochemical uncontrolled, there were 12 patients. Complete normalization of excess hormone was seen in 41%, and reduced status was seen in 35% of our treated cases. We also do radiosurgery of functional diseases. This is our planning image of primary trigeminal neuralgia. Our data for primary trigeminal neuralgia, total cases are 95. No follow-ups were seen in 21%. Age range from 21 to 82%. Post-radiosurgery, 88% of our patients belong to Barrow pain scale of 1 to 3. Barrow 1 is no pain, Barrow 2 is occasional pain, and Barrow 3 is some pain adequately controlled, while 12% of our patients belong to group 4 and 5 with severe pain and no relief by radiosurgery. This is the image of glossopharyngeal neuralgia. We also treat hypothalamic hematomas. Now coming to meningiomas. This is image of our treated case. An image of right paracavernous meningioma. This is our data. Total cases are 653. Grade 1 meningiomas are 535. No follow-ups were seen in 24%. Radiological progression of grade 1 meningiomas was 1%, and the radiological control was seen in 99% of our cases. Coming to grade 2 meningiomas, the total cases are 122. No follow-ups were seen in 20%. Radiological progression was seen in 12%, and radiological control was seen in 88%. Regarding grade 3 meningiomas, all were referred to us after the failure of upfront conventional radiation. Total cases were 6, and radiological control was seen in 83%. We also treat hemangioblastomas. This is the image of our treated case. This slide shows our data. Total cases are 28, age range from 16 to 60 years. VSRS surgery was done in 96% of our cases. VHL syndrome was seen in 18%, and logical control was seen in 96% of our treated case. This is our treated case of hemangiopericytoma. Now coming to craniopharyngiomas. This is image of our treated case. Another image of our treated craniopharyngioma. This is our data. Total cases are 59. No follow-up were seen in 11%. Pediatric age group was 42%. Upfront surgery was done in 91% of our cases. Pre-SRS pituitary hypofunction was seen in 25%. Radiological progression was seen in 6%, and radiological control of our cases was 94%. We also treat post-surgical angiofibromas. This is an image of our treated case of angiofibroma. This is treated case of nasopharyngeal angiofibroma. Coming to our data, total cases are 20. No follow-ups were seen in 25%, and radiological control was seen in 75% of our treated cases. We also do radiosurgery of eye pathologies, and I'm going to show you some examples. This is our treatment of bilateral hemangioma eye. This is a case of bone metastasis from renal primary. This is pleomorphic adenoma of lacrimal gland of right eye. This is our treatment of ocular melanoma. This is our treated case of retinoblastoma. A case of ocular metastasis. This is optic nerve meningioma. This is treated case of right orbit sarcoma. And the last slide is Radionecrosis carcinoma of the lacrimal gland. I must add this, that only in the case of orbital metastasis, in all other cases, the vision was preserved in our treated cases. Now coming to our SPRT data. This is our treated case of cavernoma cord. A external metastasis of breast primary. This is our treated case of synovial sarcoma of chest wall. We also treat lung metastasis. This is an example of our treated case. We also treat para-aortic lymph node metastasis. This is the metastasis to the ilium bone. A treated case of liver metastasis. A treated case of spinal metastasis. We have also treated renal cell carcinoma, incesionoma of pancreas. We also do SBRT of pancreatic cancer. We have treated adrenal metastasis. Now coming to hepatocellular carcinoma. This is the image of our treated case. Another treated case of hepatocellular carcinoma. Now coming to our data, total cases we treated are 68, age range from 47 to 74 years. Male was 61%, no follow-up was seen 22%. The size ranged from 2 to more than 13 centimeters. Child, mostly our cases belong to A or early B group. Development of new lesion was seen in 38% during follow-ups, and logical control for our treated target was 98%. And last, I present SPRT data for our treated prostate cases. This is the planning image of our treated case. This is our data. Total patients treated are 50, age range from 50 to 77 years. 20% belong to high risk, 50% to intermediate risk, and 30% to low risk group. Hormone deprivation for only 9 months we gave only in high risk group patients. In biochemical control, there was only 1 relapse in high risk group and no relapse in intermediate and low risk group. I end my presentation by presenting this slide that what we know nowadays of radiosurgery potential is still the tip of the iceberg. I thank you, and thanks again Dr. Mohsen and Shaukat Khanum for giving me this opportunity to present our data.
Well, thank you so much, Dr. Kamran. That was an excellent talk. Now our forum is open for Q&A session, and I would like to invite Dr. Fawadul Kamar for taking the questions. I can see already a lot of questions and a lot of excitement in the audience, and I will request now Dr. Fawad for taking those questions. Thank you.
Okay, thanks, Mohsen. Yeah, thanks a lot for all this, to all the speakers for their enlightening talks. And I've received a number of compliments and also the questions. So one of the questions is, in benign intracranial tumors like pituitary adenoma, craniopharyngioma, meningioma, how often do you see reduction in tumor size and after how many months? So I believe this is the question the first question that was asked. So they're asking about treating benign diseases with stereotactic radiotherapy as to how often is there any reduction in tumor size, if any, and how long do they have to wait before looking for any reduction?
Mohsen, can I answer?
Please.
Yes, and
yes, please.
For benign lesions, we do follow-up imaging of MRI after every 6 months, and after that time, we normally see reduction of the tumor size, starting from pituitary. In non-functional pituitary, we do 6 monthly follow-up, but in functional pituitary, we have a protocol of giving them anti-secretory medication for 6 months and then 2 months drug holiday, and then repeat their hormonal status after 8 months. Coming to craniopharyngiomas and all other benign pathologies, we do our follow-up images after 6 months, and we have seen a reduction of tumor size.
Okay. Thank you. So the other question is, can we do stereotactic radiotherapy in the prostate after transurethral resection of the prostate? So after TURP, can stereotactic radiotherapy is safe and can it be offered?
Yes, it is safe and we can do it. And there is no contraindication for patients who have undergone TURP for SPRT.
Okay, brilliant. Thank you. Any other questions I can't see any others. Yeah, I mean, the questions are still coming in. So there's one more question. In hepatocellular carcinoma, is stereotactic radiotherapy used as a definitive treatment modality or as a bridging treatment before transplant? They are asking about HCC.
Yes, both options are available. In our country, mostly patient present with a large volume HCC, which they cannot undergo a resection or transplantation. Then we offer them curative SBRT. In our data, we have seen almost 98% tumor control of our treated lesion. The only problem is that there is recurrence of the HCC in location of the liver far away from our treated lesion. And we can even go do SBRT for the purpose of bridge therapy. Both options are available, and in both the setting, SBRT has an excellent response.
Fawad, sorry, if you allow me, we have a lot of questions in Q&A.
Oh, I see, yes.
I am not sure if you have access to that. Before taking those questions, I have a question from Dr. Stephanie Weiss. Stephanie, are you with us?
Yep. Hello.
Oh, hi, Steph.
Hi.
Nice to. Thank you so much for joining us. It's a real pleasure. It's a real pleasure to see you, actually. And I have some questions with from Dr. Waqas also. But before going on to Dr. Waqas, I would like to ask Dr. Stephanie Weiss about a cavity stereotactic radiotherapy. Like, what are your recommendations on that, and what do you typically include in cavity SRS? Like, do you take the surgical changes or the flap, or is it only the cavity? What are your recommendations on that? Thank you.
Yeah, that's a great question. Thank you so much. And thank you again for having me. This is a real honor. So, in the cavity setting, the postoperative setting, you definitely do not want to include the flare, right? The edema is just going to be that. It's normal brain with irritation. In terms of what your actual GTV is, it is a challenge. And it's actually the margin of the cavity, really right the edge of where you see the cavity, but excluding the surgical tract. So the preoperative scans are really helpful for that. You want to look to see where the tumor was and use that to guide what is true cavity and what might be just surgical tract. And on top of that, you're keeping in mind any shift in the brain that comes from relief from mass effect with the extraction of the tumor, and additionally, because of reduction in edema. So it's really challenging, and it's thought to be that this may very well be why postoperative radiosurgery has a surprisingly high incidence of both failure and radionecrosis. Ironically, I used to kind of scoff quite a bit at the fact that in the United States, at least, I don't know how it's done elsewhere, but historically, because radiosurgery was initially developed by a neurosurgeon back in the days prior to radiation oncology even being a field, by, of course, Lars Leksell from Sweden, surgeons got themselves involved in radiosurgery, which I think it could often do more harm than good. You know, they had a hammer, so everything looked like a nail. And so I really kind of said, if I needed one partner in doing intracranial radiosurgery, it would be the neuroradiologist, not the neurosurgeon. Having said that, in the postoperative setting, the neurosurgeon can be really critical because they can really help you define the target and what might be just gliotic tissue or what might be the surgical tract. So a long answer for a great question.
Well, thank you so much, Stephanie. The other thing, what dose and fractionation do you typically use in this setting, like in post-op surgical cavity?
Yeah, the optimal dose is not well defined. Really, we still tend to use the old RTOG 9005 doses. In the United States, if it's typically less than 2 centimeters, 18 gray, 2 to 3, we dose reduce, less than 2 centimeters, 20 gray, 2 to 3, 18, and 3 to 4, 15. But having said that, there's a lot of data out there nowadays that supports doing hypofractionation. There's Choi, who is referenced in the slides I sent, who essentially looked at control in the postoperative setting. And what they found was because postoperatively, the cavities tend to be somewhat larger. I should say probably the GTV can be somewhat larger than it was in situ. They felt they were safer going to a SRT mode. And what they did was they would contour out the GTV, put on a 2 millimeter margin, and then hypofractionate. And what they found was control was superior. So what was interesting about that is, on the one hand, people think of hypofractionation as dose de-escalation, which may or may not be true. I think we often forget that our radiobiology for high dose fractionation is really, the modeling is not accurate. We make an assumption that's not necessarily true. The BED formulas break down. But the control was actually better in spite of hypofractionation, suggesting either, again, the BED is a lot more complex than we're thinking, or that, other elements of radiobiology, like allowing multiple fractions to let the cells cycle, is an important feature that we've been ignoring more recently. Or perhaps just we're targeting better by getting more, by putting those little margins on, which we can reasonably safely do with hypofractionation. So if we hypofractionate, I tend to do either 800 times 3, more recently moving to 900 times 3, keeping in mind there's an alliance protocol, I forget the number, but it looks at single fraction versus hypofractionated radiosurgery in the postoperative setting. And they have very nice, clear guidelines for what the dose should be if you're going to hypofractionation.
Well, thank you so much, Stephanie. And I would like to give the mic to Fawad. If I'm sorry to hijacking your session, but you are welcome to get any other questions asked from Stephanie, or I think there are a lot of questions for Dr. Vikas also.
Yeah, absolutely. So one of the questions is, for 26 gray and 5 fractions, what is the practice recommendation for doing portal images or NCBCT? And also one of our consultants has asked about how commonly in your practice VMAT breast planning is being used. So one is about VMAT breast planning, and the other one is portal imaging for the fast forward style treatment.
Thank you, Fuad. I hope you can hear me well.
Yes.
Well, in terms of portal imaging, daily portal imaging is being done at the moment in our center. And there is no extra cost for that. In terms of radiation exposure, it's quite acceptable. Secondly, if we talk about considering VMAT, we preferably doing VMAT in IMCs. When we are including the internal mammary chain lymph node radiotherapy, then VMAT is the preferred choice. It's easy to plan, quick, and it gives you a better dose distribution with more reliable dosimetry. So that's what our practice is.
Okay. And one of the other questions to Dr. Kamran Rashid is that, what dose are you using for large skull-based chondrosarcomas?
We give 40 gray in 5 fractions.
Okay, fine. And the other question is, how many brain metastases can be treated with stereotactic radiotherapy at one time? I think this is a question for Professor Stephanie Weiss.
Hi, so how many metastases in one session?
Yes, please, yeah.
Yeah, another great question. So the short answer is we really don't know what the upper limit is. The longer answer is that the best data we have is, I would answer this by saying the highest quality data we have basically confirms that we can do radiosurgery on 4 lesions without any compromise in any way that we're aware of for these patients. But if you're really thinking about it in terms of safety and volume, there's this great, I think it's Yakamoto, I may have the name incorrect, and I apologize for that, but it's a Japanese study, and it's phase 2, very clever study. Trying to do, they looked at patients with up to 10 metastases, and rather doing a randomized trial, which, you know, is the gold standard, but takes a long time to accrue. What they did was they stratified patients who had either 1 MET, 2 to 4 METs, or 5 to 10. And they all had radiosurgery. And what they found, they brought in the assumption that we know if a person has 1 MET and gets radiosurgery, there's a survival benefit compared to patients who have more than 1 MET. We know that from Roy Patchell's surgical data, and we know that from RTOG 9508. So that's taken as given. And we also know from randomized data that you can not have a detriment in survival if you do radiosurgery to up to 4 lesions. So what they did was they said, okay, given those 2 things that are taken as given, in this study, how do patients with 5 to 10 lesions do compared to those with 1 to 4 lesions? What they found was, as expected, patients with 1 lesion had better survival than patients with more than 1 lesion, but patients with 2 to 4 lesions had the same outcomes in terms of survival as patients with 5 to 10, suggesting, I mean, and the curves were superimposable. They're just right one on top of the other. They were the same. So it suggests that patients who have 5 to 10 lesions can be have radiosurgery delivered and do equally well as patients with 2 to 4 without any detriment. So it was a very clever study. And so in the United States, and this is a terrible reality that this is how things are thought of, but if the insurance companies will pay for it, then it's sort of considered acceptable. And the insurance companies do pay for it. So it's considered robust data. There are active studies now looking at treating up to 15 METs. My guess is that in the majority of cases, that will be fine. I think it's the volume of disease that's more important than the actual number of lesions. And finally, I'll leave this with, there is data, or reports, I should say, coming from Asia of treating 20, even up to 30 lesions. But again, that is not standard, and I wouldn't recommend doing that off a protocol.
Okay, and I would just take in one last question from here. With the emergence of hippocampal sparing whole brain radiotherapy, is stereotactic radiosurgery justified for brain metastases? I think, again, thanks a lot, Dr. Stephanie, for answering this.
Sure. So really interesting question. What I find most interesting about it is the way it's phrased. With hippocampal sparing, is radiosurgery justified? I think the way we think about this is sort of the other way around. With radiosurgery, is even hippocampal sparing radiation justified? And the reason I say that is hippocampal sparing is felt to work based on randomized data. So certainly something that if it can be delivered for a given patient who requires whole brain, or that's the way it should be done. But having said that, I think it's really important to remember, and even Vinay Gandhi, who led these studies, will be the first to admit that while the sequela of whole brain is felt to be, at least in part, to dose to the neural stem cells in the hippocampus, that's not the only mechanism of neurosequela from whole brain radiation. We all have seen, for instance, the white matter changes, the leukoencephalopathy that occurs, which may or may not be associated with clinical detriment. But there are these other changes clearly going on. And as Dr. Farid will certainly tell you, one of the things that I learned in my training and has served my patients well is that radiation and whole brain radiation in particular can more commonly be associated with normal pressure hydrocephalus than you might realize. And what's so important about this is not only is hippocampal avoidance not going to spare a patient from this, but it's a potentially reversible cause of neurocognitive deficit. So to remind everybody, NPH is the wet, wacky, and wobbly symptoms. They can develop urinary incontinence. I think the most profound thing that you can see is what's called a magnetic gait. They kind of walk as if they have magnetic boots on. And you can see particularly when you ask somebody to turn around, walk to the end of the room, turn around and walk back. And then they have neurocognitive changes. And this is something that is underdiagnosed in the population in general. People think, well, grandma's just getting older. And sure, that's associated with MPH, but what's important is it's potentially reversible. And what you do is you send the patient to somebody who can do what's called an extended lumbar drain. And they basically do a lumbar tap, but take out a higher volume than you do with a normal lumbar tap. Very often you admit somebody to the hospital for a day and they just do this drain. And you do a physical therapy exam before and after the drain. And if you have a diagnosis of NPH, the patient will get much better in terms of their cognition and their gait. And what that tells you is, assuming the problems reaccumulate, which they eventually usually do after a drain, you can decide with the patient whether or not the improvement was sufficient to talk about doing a ventriculoperitoneal shunt, which can be a permanent fix. So again, I'm sorry for another long-winded answer, but to a great question, which is certainly if you can reasonably avoid even hippocampal whole brain radiation, it's worthwhile, simply because there's more than one mechanism for the detriment of whole brain. But there are certainly instances when you need to do it, and hippocampal avoidance does seem to be superior in terms of preservation of neurocognition compared to conventional whole brain.
Well, thank you so much, Dr. Weiss. That was extremely helpful. I have a question for Dr. Waqas, and it is how commonly in your practice VMAT breast planning is being used?
Sorry, how common is that?
In your practice, VMAT, how often are you doing VMAT?
Yeah, I mean, just to clarify the last answer, that there were two parts of that question before I answer you this one. That 26/5 should not be used if we are doing internal memory chain lymph node radiation, because those patients are excluded from fast forward trial. So yes, the other, now coming to the current question, the VMAT is a very useful strategy for patients who need internal memory chain lymph node radiotherapy or any difficult anatomy like pectus excavatum, where the chest wall are not very normal in shape and there is more chance of nipping to the contralateral breast. So in that kind of a scenario, you can use the VMAT. We are more commonly using VMAT for all internal memory chain lymph node radiation. And if we meet the constraints, we include it. If we are not meeting the constraints and the hard dose is going too high, then we revisit our plan and we talk to the patient about excluding internal memory chain lymph node radiotherapy where it is appropriate to do so.
Thank you so much. I have a question for Dr. Ahmed Aldeeb. Ahmed, are you with us?
Yes.
Oh, thank you so much for joining us. It must be early in the morning. So regarding the chest wall constraints that you typically use, what are your constraints and how often do you get this problem? Because for the lesions that are peripheral in the lung, you sometimes run into this issue. And do you have a specific strategies to counteract those?
So the constraint that we usually use, do you hear me well?
Yes, of course.
Yeah, sure. So the constraints that we usually use when we do the lung SPRT For the so we were told in the beginning to use to try to limit the chest wall to 30 cc. 30 gray shouldn't exceed 30 cc. But but our physicians now they think this can be. Sometimes we choose to change this to 37 instead of 37 gray. So instead of 30, based on some studies, I don't have the study, but I can check with a physician who changed this. It's one of our attendings here, Samira. Maybe, I don't know if, yeah, so I can check with her, but now it's like, because the thing is, her comment was, we have been using 30 cc, whatever the fractionation we were using, like this was 30 gray, 30 cc for 5 fractions or 3 fractions or whatever fractions. So it's like, it was not really a strict thing. So that's why she based on a study, she said she sometimes accepts using 37 gray. So that's what we usually do. That's for the chest wall. But for the ribs, we usually, if it's 5 fractions, usually it's around 57. We are following Timmerman.
Okay, and how important do you consider D2 centimeter? Like, I know there are different ways of approaching this, but what are your, does it depend on the location? So if we talk about the intracranial SRS or SRT, so what is the constraint that you typically use for D2 centimeter?
So usually this D2 CCM is for the, like we usually mainly use it. For me, I usually do SPRT cases. Maybe Stephanie can comment on the SRS, but I usually use the D2CM for the, mainly I think it's in the RTOG protocol for the lung. And so that's why we use it. This is defined for in the RTOG for the lung. So we usually use it especially for the lung cases. However, I still try to use it in the abdominal cases also, like, since it's good to try to improve the fall off. How strictly we are using this, it depends on the case. So most of the time I try to make sure that 50% of my, especially depending on the size of the target, I try to make sure that the 50% is within this 2 cm. But sometimes some cases are really complicated. So this would be the last thing I will look at because I will care more about the critical structures.
Well, thank you so much. And we had an exciting session. And I thank you all the panelists for that, Dr. Waqas, Professor Stephanie Weiss, Dr. Kamran Saeed, and Dr. Ahmed Aldeeb for coming with us and taking us through this journey of new advancements and the exciting stuff that has been going on in the field of radiation oncology. I wish we can meet in person sometime. And I wish you all the best for your health and everything. And with this, I will conclude this session. And I once again thank you to all the participants and the panelists for joining us. Thank you so much. Bye.